try to honor the 1 hour time commitment. We'd like to begin this event by acknowledging that no matter where we are in the virtual event, we're meeting on Aboriginal land that has been inhabited by Indigenous peoples from the beginning. As settlers, we're grateful for the opportunity to meet here, and we thank all the generations of people who have taken care of this land for thousands of years. We'd like to begin by acknowledging that we meet on the traditional territories of the Mississauga, the Haudenosaunee, and the Anishinaabe nations, and within the lands protected by the Dish with One Spoon Wampum Agreement. We give honor and thanks to the Mississauga, Haudenosaunee, and the Anishinaabe nations as the traditional inhabitants of the lands where all of our panelists live and work. To say that is to acknowledge a debt to those who were here before us and to honor and recognize our responsibilities as guests to respect and honor the intimate relationship Indigenous peoples have to this land. We seek a new relationship with Aboriginal peoples of this land, one based in honor and deep respect. May we be guided by love and right action as we transform our personal and institutional relationships with our Indigenous friends and neighbors. We want to inform everyone we are recording tonight's sessions and it will be made available along with the slides. We'll have those available for you for tomorrow morning. As we turn to the agenda, and I will share my screen now. The agenda calls for, I'll invite Julie, the WSIB Executive Director, up in a second, but we're going to talk about the review the gas purpose and resources briefly. We will answer a number of questions we have received in the last month or two. We'll also feel we'll have time for an open question period as well, and then Julie and I will close the session at the end. The structure tonight is that we've taken the feedback and follow-up questions from the first two seminars, as well as questions we received from our cast out, and grouped them into themes, and we've provided answers. However, we do anticipate, as I said earlier, to have an opportunity for some live questions as well. So I'm going to turn it over to Julie Thurl, the Executive Director, who heads up the WSIB Health Services Division. Julie?
Thank you very much, Richard. And I want to start this evening by thanking OPA and inviting us to the session with you tonight so that we can hear and be a part of the discussion and ensure that GAS can be successful for all of us. We do recognize the fast pace of the rollout and that it wasn't necessarily ideal. We would have preferred a launch of this in one-year conferences where we can have face-to-face engagement, which was ultimately our initial plan. But the pandemic has thrown a lot of loops at us, and unfortunately this became our reality in the virtual space. But this virtual environment comes with challenges, but also a significant number of positives, and we definitely have benefited from them. One, of course, is the significant increase in access to care for both our injured workers, your patients, and Ontario overall. We do recognize the commitment and the time and the effort you have dedicated to pivot to this and ensure continuity of care in this very busy time. We are pleased to join you this evening and take time to share more information about the purpose of GAS and the purpose to support better communication for all of us. We know this isn't about just WSIB. This is about you and your practice as well, and we hope that you also see value in this for your practice. Of course, recognizing that our patient population may only be a small portion of all those patients you treat. We have heard some feedback to date, and we appreciate it. We have taken it into consideration of how better to support psychologists in transitioning to GAS. With this feedback, we've also heard some very positive excitement from early adopters and seen some excellent goals being set in recent reports. Jessie has also recently shared some great conversations we've had lately with many of you. So thank you again for taking the time to share with us and for attending this evening. We really do look forward to continuing to work with you. Thank you very much, Richard.
Okay, Kim?
Yes, thank you. And thanks as well for the invitation to speak tonight. I'll speak for just under about 10 minutes and then we'll move on to really the substance of tonight and getting into some of the more detailed questions. But before doing that, it might be helpful to sort of keep those questions with a bigger picture in mind and use some foundational elements of that bigger picture to guide your thinking around some of the how-to kind of detailed questions. And so the key question, I guess, is, guiding that is, what are we aiming to accomplish in making this change? You've asked for WSIB's perspective and expectations, but kind of panning out from that for a moment, there are many client-centered reasons to include something like goal attainment scaling in clinical practice, such as increasing meta-communication about therapeutic goals or therapy process, which hopefully supports therapeutic alliance, helping to set intentions. What is the person with your help hoping to impact in the course of undergoing intervention, participating in it? Hopefully it supports client motivation, particularly when they're able to identify goals that are personally meaningful to them. Where there are several care team members, it can help with coordinating services. It can help to check in, to see, are people benefiting from interventions, and when they aren't, to adjust and pivot to increase the likelihood of benefit. And in those cases where people seem to be approaching a ceiling in terms of benefit, checking in with goals and goal attainment can help with increasing insights on the possible limits of recovery in order to then maybe aid acceptance and coping with what is. And given the move in the field toward progress monitoring as part of ethical and effective practice, goal attainment scaling provides an opportunity for psychologists to be at a forefront of that change, to be leaders and thought leaders in best practices. And psychologists have much to offer in terms of evidence-based approaches. So that was panning back to the bigger picture, and then turning back to the WSIB perspective that you've asked about. The bigger picture in the WSIB context is we're aiming to improve the recovery trajectory of injured and ill people by improving communication with WSIB and helping WSIB understand what's happening in therapy. Essentially, goal attainment scaling is there to help demystify therapy for WSIB staff who manage claims. It's helpful to know what the goals are in and of themselves. What are you working on? And reporting those goals can help with that understanding. So for example, if I report that we're working on behavioral activation, that is short-term language that many mental health practitioners will understand what I'm conveying. Non-mental health practitioners, in comparison, may find it more meaningful to see that a goal is being set to leave the house for 10 minutes a day or work on increasing social contact or engage in meaningful activities. Still behavioral activation, let's say, but using different language to convey that to a non-mental health practitioner. It also helps WSIB understand, is the therapy helping the person progress in their attainment of goals? Is there change happening that is helping people feel better and helping them do better over time? And in considering whether there's goal attainment and progression, it's an opportunity to discuss with the injured person, with WSIB, what else might that person need in support of their recovery? If they're progressing well in treatment, are they ready to broaden their goals, to consider occupational goals? Is it time to start addressing any workplace factors or non-injury related barriers to recovery? Are they ready for return to work services support? If there is little or no progression across time, do they need help setting more realistic goals? Do they need a medication review? Would some temporary adjunct treatment or more intensive treatment assist them? Sorry, Richard, I'm still on that prior slide. Thank you. Would involvement of return to work services help to address workplace factors? So the goal attainment scaling section of the report does require some detail, and that's where a lot of the questions have been hovering. So you will be reporting on SMART goals and reflecting on whether those goals are met, but you won't need to write up every small progressive step. So there's the intention that is set when the goal is set, and then there's checking in with whether or not that goal was attained. You probably don't want to have to write up every micro step along the way, and certainly WSIB won't want staff receiving the minutia. Next slide, please. Next slide, please. Thank you. So all of that helps the case management team do their own goal setting in response to where the injured or ill person is in terms of their current needs and their current functioning. Without that information, case managers might not fully understand what's happening in treatment, and so they may reach out to you with multiple phone calls or requests for clarification or additional information. So hopefully this reduces some of that outreach and ultimately saves you some time. Seeing the goals also can help them understand and contextualize the other information you place in your report, such as why are your return to work recommendations what they are. They may have some context when they look at what are the nature of the therapeutic goals at that time. And if you're moving forward with something different in treatment or requesting an additional block, it can really help them to see what are the goals that have been working on and what are the comments around what has been helping or impeding progress, so that they then better understand why another block is being requested or why the focus is shifting. So rolling out goal attainment scaling is a process, and we can come back and continue these conversations. We can share with you how it looks like it's working from our perspective and hear your views as well in terms of how it's working for you and for the injured, ill people with whom you work. Next slide, please. So tomorrow we'll complete our internal training of goal attainment scaling across all of the nurse consultants, return to work specialists, and case managers at WSIB. We planned it so that the real-time training would align with when your reports are likely to start coming in. And in those trainings, we have communicated those key points that we just reviewed with our internal staff as well. So I've led and been present at all training sessions. So there's been a psychologist voice at all training sessions. We've messaged that again, the primary purpose of goal attainment scaling is to improve communication between everyone and to better understand what's being worked on in therapy and what the recovery trajectory looks like. We've emphasized to staff that goal attainment scaling is just one tool that just provides a little more detail about what's happening in therapy to help them understand. We've emphasized that nothing else changes. Roles and activities remain as they were prior to this initiative. We've also described the implementation of goal attainment scaling as a journey and a transition period. So internally, we've messaged to staff that they should not expect all goals to be SMART goals or to be perfectly accurately SMART goals right away. They do know that as of June 1st, goal attainment scaling, the section in the reports is active and you'll be reporting on it. But we've also really encouraged them to read the comments section to understand context if they don't see SMART goals right away. We've told them that there may be clinical reasons that it doesn't make sense to switch right now to SMART goals, and again to look at the comments section in the GAS part of the report. And we've also emphasized that if they don't see SMART goals right away, they should not assume that that's a quality issue. And regardless, if quality concerns arise, Carly, Jesse, and I will be involved and will be aware. And so we have an understanding of this initiative and the transition period, and we can manage that internally. Next slide, please, Richard. So before turning to answering some of your specific questions, this is just a brief reminder that OPA and WSIB have developed several resources and reference materials to support and assist you in the transition, should you want them. So on OPA's CMHP webpage, there are several documents that we've created that are available as optional supportive documents, and I'll highlight some of these in a moment. Next slide, please. And then on WSIB's CMHP website, there is a goal attainment scaling overview document, which is kind of essentially like a quick start guide with ideas about steps for goal attainment scaling. Also that arrow diagram, some of the considerations along the recovery trajectory that you would have seen in the launch is available, linked on this webpage as well. Next slide, please. And here we'll just give you a few quick visuals of some of those documents. So this is a document OPA created with tips and things to consider when completing a CMHP progress report. And next one. OPA also created a sample CMHP report using a case example, and that includes the new goal attainment scaling section. Next one, please. This is a goal bank. Now, it's not SMART goals, but it's sort of a one-pager sample menu of goals typically set in therapy, organized under various domains like physical, cognitive, emotional, occupational. Next one. This is an expanded goal bank, so it's a sample of therapeutic goals that are organized by problem area or topic, such as anxiety, anger, mood, sleep, occupation. I think it's 6 or 7 pages in total. Next. OPA developed a repository of sample SMART goals, and later in this webinar, Bruce will be speaking to this new document. Next one. This is a worksheet that lists functional areas or functional domains that can be impacted by psychological injuries and conditions. So it could be used as a worksheet with a client or as a prompt document for yourself. Just in what ways might a condition be impacting various functional domains in life, and how might that inform what would be meaningful goals that a person may want to set in therapy. And then finally, the next one, thanks. This is a worksheet for recording and evaluating SMART goals. It mirrors the section on the CMHP report. So if you work this way, it's a worksheet that you could use with clients when setting SMART goals, and then also when revisiting and discussing them. And now I'll hand the mic over to Faith and Bruce to talk about some of the questions that have come in.
So as Kim has indicated, we've sort of been collecting a number of questions over the last number of months that have come up, and we're going to take the opportunity here to just go through some responses that we've come up to and how to handle some of the different aspects or tricky aspects of doing goal attainment scaling, and in particular how to implement the SMART goals portion of that. So the first question that we have here is, what is the time frame for setting and evaluating SMART goals? And this question is really kind of encompasses several questions that we received on this topic, such as, do all SMART goals need to be started in session 1 of the block, and progress evaluated in the last session of the block? Or questions like, when I'm trying to set goals, what do I do in situations where it's not possible in session 1 to predict where the patient wants to be at the end of the block, which could be 6 to 8 weeks in the future? So these questions kind of speak to the issue of how much flexibility we have in terms of setting SMART goals. And GAS is not really meant to be a rigid system where all SMART goals need to be established in session 1 of the block. Goals should be established when it makes sense clinically to do so. And this may happen at other times during the block of treatment. So some patients, it may make sense for them to use the start of each block as an opportunity to set goals, but for others, this may not make sense clinically, and goals need to be set at other times during the block. Similarly, the duration of the goals does not have to be a fixed number of sessions. For example, depending on the goal, it may be artificial or impractical or unrealistic in session 1 to be asking the patient where they want or expect to be at session 6. Goals should be evaluated when it makes sense to do so. So we might set a goal in session 2 and evaluate it in session 4 or 5 because it makes clinical sense to do so at that time. What you do have to do is report on the goal achievement at the end of the block. So at that time, you can report on all the goals that were set and evaluated during the block, regardless of when during the block this took place. And as Kim was pointing out, just remembering that the main purpose of GAS is to help WSIB understand what is happening in therapy and whether the patient is progressing. So it doesn't really matter when the goal was set or achieved during the block. The clinician can still communicate progress on these goals at the end of the block. Next question over to you, Faith. Oh, you're still muted, Faith.
Someone had to be the first one to start talking without unmuting. I guess I win that prize. I'm sorry, everybody. But this next set of questions does build on what Kimberly and Bruce have just spoken about. And questioning similarly, what about when a goal needs to be broken into small steps? The goal may evolve and change over the block of care, or I'm really working with my patient on weekly exercises and tasks. How do I set and report on those without having too much minutia, as Kimberly mentioned when she was talking, to put on a report? And I think it's important to kind of just go back to those first principles Kimberly was mentioning, reminding everybody that SMART goals that we're putting in that section, to the degree possible, are intended to be specific, measurable, achievable, relevant, and time-bound. And I think if we keep those ideas in mind, it will help guide how we frame and write up and evaluate the SMART goals. Also, to remember the dual objective of both supporting the patient's progress towards recovery as well as enhancing the communication with the WSIB. Because of that, the progress on the SMART goals does need to be evaluated and reported on at the end of the block of care. That's part of how we're communicating with the WSIB about what we're working on in treatment and how it's going. But some of the SMART goals will have been set at the beginning of the block of care and evaluated in the final session. But that may not be how it is for many of the goals. The completion of each SMART goal may vary between patients, between goals within a patient, between phases of treatment. As Bruce has indicated, some goals may be achieved in 1 or 2 sessions. Other goals may take 1 block. Some goals may go on over 3 or 4 or more blocks of care. Some may take even longer. Achievement may require many very small steps. And there, when we're thinking about achievement, achievable being a core aspect of the goal, we want to try to look at what steps are needed to achieve the goal. Monitoring and modification may be needed, and that's part of the GAS process. And the progress report then may report the summary of progress over the block of care, and any particular issues would be identified within the comments section. Now, next slide, back to Bruce.
So our next question here is, how do you report that the patient is not meeting expectations and not have the patient see it as failure? So if the patient is struggling to meet goals, we certainly don't want to be reinforcing feelings of failure, particularly since they may already be experiencing feelings of low self-worth or hopelessness. So the question here is, how do we talk to patients when goal expectations are not being met? And so a couple of thoughts on this. And first of all, given that SMART goals would have been set collectively by the patient and clinician, there may be an opportunity to share ownership of the outcome when goals are not being achieved. So being able to say things like, perhaps we set the goals too high, or I guess we didn't realize this was going to be as difficult as it turned out. So it's not necessarily all on the patient when goals are not being met. Secondly, you might want to think about goal achievement as more of a process and not so much as an outcome. So not achieving a goal as expected is an opportunity to explore why the patient struggled to meet the goal and what they might do next. So the focus then becomes, what did we learn from this and what do we want to change at this point, rather than the fact that they might not have met the expectations. And lastly, from a cognitive therapy perspective, not meeting goal expectations may provide an opportunity in therapy to explore negative thoughts that may get triggered. Things like, I never succeeded anything, or this will never work. Maybe a chance to explore negative coping behaviors as well, such as a tendency to give up in the face of adversity. So there may be opportunities here where sort of not meeting expectation allows you to help the patient to develop better resiliency when things don't go as planned. The next question we have here is how do I create SMART goals when a patient is very discouraged or who is angry at the employer or at WSIB and is really not ready to identify any goals? So with these patients, there may be an opportunity to establish some very basic goals. Just getting the patient to commit to showing up for the next 5 therapy appointments might become a SMART goal. Or the goal might be simply having the patient read something about their problem, such as what is depression. For the angry patient, they may benefit from agreeing to write down the things they're angry about. Above all, however, in trying to set the goals with patients who are either resistant or distressed or lower functioning, we're going to want to use clinical judgment here. Don't do something that is clinically contraindicated, such as something that's going to damage rapport. SMART goals are a means to an end. They're not an end in and of themselves. They're, as Kim has pointed out, a method of helping a patient progress in therapy, and they serve to enhance communication with WSIB about what is going on in therapy. So if there's a barrier to patient establishing SMART goals, simply explain this on the progress form in the comments section. And by doing so, by indicating the problem you've had establishing SMART goals, you're still helping WSIB understand what is going on in treatment and where the patient is in terms of progress towards their goals. And my last point here is sort of remembering that just because you might not have SMART goals does not mean you don't have goals. Your goals may still be to increase motivation for treatment or reduce anger or increase activity. So just make sure you communicate this in the other areas of the progress report.
So our next question is kind of not something that happens too frequently, but it can be challenging when it does, where we have a patient who is unrealistic and setting goals that they're not likely to be able to achieve. What do we do? And again, the core message that we're all giving tonight is that the SMART goals are really only one component of the work with the patient. And we may need to consider the traits that the patient is showing towards impatience or not being aware of barriers that they're facing and how that carries over into all of the work we're doing with them. And just a few thoughts around ways that I've considered how I might approach that with my patients. That I might consider a SMART goal is to do some psychoeducation around behavior change principles. I might work with the patient on approaching the SMART goal as more of an experiment with ongoing monitoring and modification. And also, if the patient sets goals that are overly ambitious and is not able to meet their targets as expected, one might put the context of that and the explanation for it in the comment box to help both the patient understand it as well as the WSIB. Bruce, you want to follow up on that with the next one?
Yeah, and the next question is also addressing the issues of what's happening here in terms of the goals and what do I do if the patient is failing to achieve their goals, their SMART goals in particular. And in most ways, the therapist's reaction to a patient not progressing on SMART goals is the same as what it would be for any patient not progressing in therapy. So it's usually time to be doing some detective work around what the problem is. So asking yourself, why is the patient not progressing? But of course, you may also decide to ask the patient why they may be having difficulty. As often the patients have insight into the problems that they've been experiencing. In terms of some more specific things that one might consider, is kind of getting back to the SMART goals, the whole tenets of SMART goals as well. Was the goal set attainable, achievable, or realistic for the patient? For example, if the patient experiences too much anxiety or depression at that point in time, is that getting in the way of them achieving the goal? Are they too fatigued or too reliant on avoiding coping habits to be making progress on that particular goal at this time? Are the goals relevant to the patient? For example, a therapist may see the importance of exposure therapy or exercise or mindfulness, but the patient might not, and therefore might not be following through as expected for that reason. Are there barriers present that are unrelated to the injury? So family stressors or anger and sense of injustice, low motivation to return to pre-accident vocation. Do these types of factors need to be addressed first before progress on other goals can be made? Do I need to change therapy? Would they benefit from a different therapy approach? Do they need something more than individual psychotherapy? Would they benefit from medication or psychiatric referral? What resources does WSIB offer that might be helpful? And again, this is one thing that maybe sets these patients apart from some of the other patients that we may deal with, such as in auto insurance, where there are other resources that WSIB can facilitate, such as would they benefit from referral to another provider, such as a neuropsychologist or an occupational therapist or rehab therapist, or do they require or benefit from referral to one of the specialty programs? And there's going to be some situations where you'll need to consider whether the patient is unlikely to make further progress and has reached a plateau in their psychological recovery. So if the patient is not progressing on their goals, whatever you are proposing on your progress form for their treatment should include some indication of the problems and how these are being addressed in future treatment. The next question here, what if the patient is actually making good progress in treatment, but not making progress on their SMART goals? So some patients may struggle with the SMART goals, but be showing good improvement in other respects in terms of their treatment. Again, as has been mentioned earlier, not all therapy goals are represented by the SMART goals. And SMART goals may not even be the most important goals in therapy for a particular patient. So progress is not all about SMART goals, and not everything that happens in therapy gets described in the GAS section of the report. So you certainly want to make sure that the other areas of the form, in particular the response to treatment section, explains to WSIB how the patient is making progress in the other areas. And as Kim has pointed out, WSIB is providing training to their own people in terms of to look to the other sections of the form and not just the SMART goal attainment section of the form. WSIB is likely to be confused though if you report low success on most of the patient's SMART goals, but indicate that they are making moderate progress overall. You don't then go on to explain how they are making that progress. Okay, Faith?
Okay, and we've been talking about goals. Often it's assumed that all those goals are directly and in a very immediate way related to return to work. And so there's a relevant question that's raised about what if the patient does not have the goal of return to work? And there's two different groups of patients that in my practice I've had to think about this way. Some of the patients I've seen are retired or have been determined to have a permanent impairment, which means there isn't a goal of returning to work, but the WSIB is supporting their receiving psychological care in order to improve their quality of life. And SMART goals are very relevant here, and those SMART goals can relate to symptom reduction and functional restoration in other areas of their life, including their personal life, their social, and their recreational functioning. However, there's also another group of patients for whom ultimately return to work is a very relevant consideration. But they may not be yet at the stage where they're ready to look directly at specifically occupation-related goals. And for those patients, working on SMART goals for symptom reduction and functional restoration in other areas of their life, including personal, social, and recreational functioning, should be relevant to helping them move toward a return to occupational function. Another question that has come up is some confusion about the role of occupational therapists and SMART goals. And if somebody is working with an occupational therapist, should the psychologist working with the patient also have SMART goals? Change in monitoring progress. They're not limited to psychological treatment, and they're used in a variety of contexts. So if somebody is working with another clinician, whether it's a physical practitioner or an occupational therapist, and they're using SMART goals, the issue as I see it is not the SMART goals themselves. The issue is when our patients are seeing multiple healthcare providers, they really do benefit if there can be, with consent, collaboration between the psychologist and the other treating health professionals. That way we can make sure that there is the risk of confusion is reduced and we can avoid duplication. It also may be essential to ensure that the patient is not overwhelmed with too many tasks to be working on simultaneously between the sessions. Thank you. Bruce, I think you're going to speak now about our examples.
Yeah, so I'm going to take just a few minutes to introduce you to an additional document that OPA recently created to try to assist with SMART goal setting. Kim referenced this document earlier when she talked about the optional resources that are available to clinicians. And this is or will be on the OPA site. So this document list is a list of examples of SMART goals, and we wanted to show the diversity of SMART goals that one might use in therapy, depending on the patient's needs and situation. So the slide in front of you right now is just the first page of this document. The examples are organized using the same categories found on the Goal Bank documents that Kim referenced earlier that you can find on the OPA site. So there are SMART goal examples for symptom reduction goals that include emotional, behavioral, cognitive, and physiological symptoms. And there are examples for functional restoration goals, including personal functioning, social functioning, and occupational functioning. The categories are overlapping, however, so some goals can fit into more than one. So on the first page here in front of you, you can see that we're in the emotional symptom category with different emotional symptoms present down the left-hand column. We also used a stages of change or readiness to change approach to further organize the examples to try to show how goals might differ depending on where the patient is at in therapy. So the goals here are further divided according to whether a person is pre-contemplative or contemplative in terms of their readiness to make change, or whether they're in more of an action stage and ready to make changes, or in a maintenance and relapse prevention stage. So on the next slide, we have an example from the document. And here the symptom that's being addressed is anxiety and hyperarousal. So if your patient is pre-contemplative or contemplative, so still uncertain about the need to make changes, your goals might be to help them understand the potential benefits of treatment. So your SMART goals might include things like writing down 3 benefits of reducing anxiety to be reviewed in the next session, or recording 3 things that they or others might notice if their anxiety was to improve. a goal might be documenting the pros and cons of reducing their anxiolytic medication, such as lorazepam. So patients in the action phase, in contrast, are ready to make changes, and so their goals will likely look different as they are more engaged or in exercises promoting change. So goals might include things like reading a handout on breathing and practicing breathing relaxation skills 15 minutes so many times a week, or reducing their use of lorazepam from, say, 4 times daily to once daily, or doing a meditation exercise daily for 5 days. For patients in the maintenance stage, their goal might be just maintaining gains that have already been made and preventing them from relapsing into more dysfunctional coping. So continuing to use breathing and grounding skills that they have already learned, or once they have stopped, to continue to not take lorazepam to manage their panic attacks. So you can see that you might have maintenance goals that don't really add anything new in terms of goals, but where it is important for the patient to continue to put attention and energy into maintaining the gains that they've already had. So this is, again, just an example of what is on the document. It's a 6-page document, so there's lots of examples here. Obviously, it's not an exhaustive list, however, in terms of interventions and goals, but we're hoping it might be something that's useful in terms of understanding how this all might come together. Okay.
Jesse, do you want to talk about some of the other frequently asked questions on the progress report?
Great, yes, thanks Richard, and thanks Dr. Baxter, Dr. Kaplan. So I'm just going to go over, I will only take a few minutes just to talk about some of the specific questions that have come up regarding the progress form, the changes that have been made to the progress form, and some completion questions. So first one up, does the GAS section of the progress report replace a section on treatment goals previously identified? So the treatment goals previously identified was kept in the new form, but it was updated. So updated for the opportunity to comment on broader goals. So these broader goals are related to symptom reduction, functional restoration, and return to work. So we really understand that these broad treatment goals might not necessarily be captured in the GAS SMART goals provided within the progress report. We know that these SMART goals are set collaboratively with the injured person and yourselves, and they're time bound, whereas the broader treatment goals can speak to the overarching treatment goals for that injured person, and this is where you capture them. So similar to this question, we have another one about the GAS section of the progress report replacing the section on response to treatment. This was mentioned earlier by Dr. Baxter, so it's not replacing this. We see scenarios where an injured person is not progressing necessarily in their SMART goals during the treatment block, or perhaps the goals need adjustment. So they're not meeting those, but overall they are progressing in their treatment plan. So overall, between progress reports, we see that progression. So this is the area where you can document that and provide the reasoning and rationale as to why that is. Another important part of this section in response to treatment is the opportunity to report on prognosis. So completely understanding that prognosis is not set in stone. It can change depending on where an injured person is in their treatment, but it is helpful to provide an idea of what that prognosis looks like in each progress form, so the injured person and the case management team can help plan appropriately for where they are in their recovery. And next question is, does the GAS section of the progress report replace the section on functional status? So the SMART goals outlined in the GAS section might not speak specifically to functional domains. We know that GAS SMART goals provide information on what interventions are being delivered to try and improve or restore function, whereas the functional abilities section is an area to report on what functional abilities or limitation the injured person has at that time of reporting. So given this, that section for functional status should really report on the injured person's overall functional status, not just the areas that are being addressed in the treatment. So information on activities of daily living, participation in social activities, the ability to concentrate should all be reported on within the functional status section. So I think this question has popped up in our chat from someone. So how will I use the new form with a current patient who does not yet have SMART goals? So we know we're in the transition period now. And I think that we can say that there is definitely a flexibility with this transition. We know that this webinar is just coming out now with some clarification in the frequently asked questions. And it's difficult. It's not everyone is going to follow the transition period exactly within your practice. So what we're saying during this transition is that you're encouraged to use the GAS section to report on the goals that you are currently working on, even if they're not defined in SMART terms. So this is a perfect opportunity to use that comment section to indicate where you are in that transition. Similarly, you may have a client that you've recently set SMART goals with, but it's at the end of the block. You haven't had a chance to work on those. They've just recently been set during the transition. So that's, again, the opportunity to use the comment section to indicate this and where you are during that transition period. But certainly flexibility with how this transition is going and with timelines regarding that. And then finally, what do I do if a case manager is concerned with the lack of detail in the GAS section? So I know Dr. Watson spent a significant amount of time going over what we've communicated to our internal case management teams and what that training looks like. So I'll just highlight here, it was really emphasized this transition period that SMART goals or the full completion of this section may not be present. So we've encouraged our case managers, like we always do, to review the reports in entirety and across multiple progress reports if they're present. And look at those comment sections when they're not seeing that section completed for where the injured person is and the answers to why it's not completed and what the transition period looks like for that specific person. We have advised throughout health services, there's a number of us helping to support this and support you. And they can come to us, or case management teams will come to us if they have any questions, and we can help navigate that GAS action when it's not completed. I will say that case managers may still contact for the same reasons that they have been before. So if they're looking for a clarification on something or have some questions about the report in entirety or overall, you may still get those questions.
Great. So now we have some time for some questions that have been, I think, in the chat or Q&A section. So I'll turn it over to Carly.
Thanks, Richard, and thanks to all the presenters. That was amazing information, really well done. So we have a couple of questions in the chat. We never know if we're going to get too many for the approximately 11 minutes that we have left. Maybe I'll round it down to 10 so we can have a couple seconds for closing remarks. So now's the time, if you have some questions, to pop them into the chat. I'll warm you up with a couple of easy ones, and I know that some of them were answered along the way with either the presentation material or as we went, we had the team in the background typing a few out. So easy question here. Where will the optional resources be found? So is that, Richard or Faith or Bruce, I may put you on the spot there too. And I know that it was mentioned as far as them being available on the OPA website. Is there a time frame that you're working towards to have the resources up and available?
Well, we'll hopefully have them up by the end of the week, if that should be doable. But if there's any delays, we'll put out a notice. But I would anticipate hopefully by the end of this week or at the very latest on Monday.
I think it's important to mention that those resources are available to everybody on the OPA website.
Yes, thank you.
So I'll just add, if it's okay, Carly, that most of the resources are currently posted. So the goal attainment scaling overview and that arrow diagram are on the WSIB CMHP site. The OPA is hosting the supportive documents, the majority of which are already posted on the CMHP site at OPA. And as Richard was saying, they will update with a couple additional pieces that were spoken to today. So check out the site now and then check it out within the week. Yeah.
Fantastic. Thank you. It sounds like lots of the material that's been developed to date is available already. So thank you for that. Another question that's come in here, and I believe this may be an OPA question. This individual is indicating that they are not certified in PGAP, but would like to know how similar this process would be to that.
I think you may be talking about PGAP, which is a specific protocol that is often used. I think it originated with chronic pain and it's being expanded out to others. So that's a specific protocol that, that people train in and adhere to, and it certainly does use goal attainment scaling, the progressive increasing of goals. I would say that it's more protocol driven and maybe prescriptive in its steps and its content than this is. So here, the spirit of PGAP is there in terms of setting goals that are SMART goals that are hopefully progressive across time, but it's not the PGAP system. I don't know if anyone else wants to speak
I'm so
to
glad whoever asked the question asked it, because there's an unfortunate overlap in the use of terms that sound so similar to imply that one is a component of the other. And while they do take a similar approach in terms of setting goals, as Kimberly has rightfully said, nothing about using goal attainment scale imposes any specific treatment approach or particular therapy protocol on what the practitioner chooses to use to meet the needs of the individual patient.
Great, thank you. And yes, so Dara, thank you for that, because I did state it incorrectly. So PGAP is in fact what was being asked about. So appreciate that response. I see another one that's come in here. Nope, just a thank you. So I want to actually go back to one that was previously responded to, but I think it might be helpful just to comment on, given that, and I believe, Richard, it was perhaps you that had indicated that virtually there's going to be an aspect of virtual that and online that will be part of our future here. So it was related to the transition to a virtual office environment. Are there plans for allowing a digital signature on the Acrobat form templates so that they don't have to be printed, signed, scanned, and re-uploaded with a significant degradation of visual quality as a result? I know that, Kim, you had indicated a response there in the chat, but I think maybe for the broader audience, could we maybe just provide that update, because there may be many more who are asking that question.
Sure, and others may wish to pipe in and add to the nuances. So this question did come up, and we consulted with the college. We try to align any of our guidance or expectations with what the college would advise. We would never want to contradict the college. And so their response was a bit lengthy and nuanced, so forgive me, I'm going by memory, but essentially, a digital signature does not have to look like a handwritten signature, according to the college. I would encourage anybody who's looking into this to contact them yourselves and get the answer directly from them. But my understanding was the recipient needs to be able to trust that the person who signed off on the report is in fact the signator. And you need to indicate your identity in some way. So it could be signed by Dr. XYZ that is typewritten into the form. So it doesn't have to be, you know, an image of your handwritten signature. It's probably wise to sign all of them the same way all the time, because that becomes sort of your identifier. So based on memory, that's my recollection of what the college's guidance was. I don't know if anybody wants to add anything.
I'd really like to thank you for that response, because it's absolutely the case that the WSIB has been very respectful of the role of the college setting expectations for professional practice. And the college has encouraged all of us through this time, when possible, to provide services in the ways that make sense for the clinician and for the patients. And many of those have been done remotely. And so having the signatures be able to be provided in a way that's efficient and effective and does not cause delays has been very important. So it's good somebody raised it. And Carly, thank you for confirming it for everybody.
Great, thank you. I'll have an easy one coming at you here now. And Richard, I believe that you responded to this one in the chat, but again, might be the questions, and I don't think I heard it called it specifically when we were talking about materials the slide presentation from this evening will be made available to participants?
Yes, it'll be made available again tomorrow. We will be able to have it available for anyone who is registered.
Wonderful. Thank you. I'm going to go to one comment here, and it was a great suggestion. Somebody has indicated that the webinar may be easier to understand and concentrate on if the material that we are presenting can be made available ahead of time, so that can follow along or even do a little bit of a pre-read. So great feedback. We'll look to take that back as a collective and see if we can get material out ahead of time in the future. And I will just see if we can get I don't see anything new coming into the chat, so I'm going to do a bit of a last call here. And Richard, I'm going to end with one last question. It's a heavy hitter for you. And the question would be, how is it that you are always at the beach for these Zoom sessions? That is what somebody in the chat would like to know.
Okay, great question. I live vicariously through my Zoom backgrounds since we've been in lockdown and unable to travel, and I'm on Zoom almost every day, almost for the entire day in meetings. It picks me up to see beach scenes, and I have about 7 or 8 active beach backgrounds, and so it just helps my mental health.
Great. And I apologize because we do have a late one that came in, and I do think it's an important one. There is a question to say, can we expect some feedback from case management on our completion of progress forms? So I may even broaden that to say, will we get some feedback from WSIB on those progress forms, and what will that look like? So that's a question that's just come in.
Sure, I can speak to that a little bit. I think that in the relationship WSIB and OPA has, we've talked about what that looks like, and from both sides, getting feedback from you, the psychologists as our providers, as well as what we're seeing internally from our case management teams when they receive the reports. I think we have a good plan moving forward to share that with our partnership, and then provide it ongoing on what's working well, what's not working well, and how we can continuously improve.
It's a great segue for our conclusion then. So thank you, Carly. Really appreciate that. I'm going to ask Julie if she'd like to, we're right on time. So Julie, if you want to talk about the next steps.
Excellent. Thank you, Richard. And I think excellent webinar, great information today, and it really shows the collaboration between our groups and really the time. So thank you, everybody. If there are still questions that haven't been answered, please contact us, being OPA or WSIB Health Services. We've left some information here for you. If it is a claim-specific question, our case management, return to work specialists and nurses are the best for those ones because they are the decision makers. But of course, please reach out to us if there's any considerations. Otherwise, we're here to help. Because this was very successful and as continued as part of our engagement, we know in the past we used to do a lot of phone teleconferences and webinars with you and address certain topics and Q's and A's that you have. So we'd like to reinstate that. We'd like to use and leverage this great technology of seeing face-to-face and having this dynamic conversation. So we will be collaborating with OPA to host a few webinars over the next period, over the next few quarters and into next year, and provide some more information specific to WSIB to help you understand why we make decisions, what policies govern us, and things such as that nature. So looking forward to collaborating with you, Richard, and I'll hand it off back to you.
Great. Well, thank you, Julie. And thanks to all of you who attended tonight. And a reminder that we will make these slides available the next day or so. So we're right on time. Have a great evening, what's left of it. And we appreciate your attendance. Thank you. Take care.